Welcome everyone to the governing body meeting in public for November 2020. Could I just ask people to introduce themselves, please? Graham?
Good morning, my name is Graham Smith. I'm a High Court barrister. I chair the Primary Care Commissioning Committee and the Individual Funding Request Panel.
Dal?
Dal Sahota, I'm a GP and I'm Clinical Director for Urgent and Emergency Care.
Rashmi?
Hi, I'm Rashmi Soni. I'm a GP and Clinical Director for Health Inequalities and the PC and DARES.
Tony?
I'm Tony Dixon, lay member and Chair of Finance.
James?
James Kent, I'm the Accountable Officer for the 3 CCGs within the Bob ICS and the Executive Lead for the ICS.
Robert?
Ron Major, I'm the Deputy Chief Officer for the CCG.
Robin?
Hi, I'm Robin Wolfson. I'm the Secondary Care Specialty Doctor.
Kate?
Kate Holmes, I'm the Interim Chief Financial Officer for the CCG.
Anyone I've forgotten?
Karen.
Sorry, Karen.
That's all right. Karen West, GP and Clinical Director for Quality and Integration.
Anyone else I've forgotten?
And me, Russell Carpenter, Board Secretary in Minutes.
Okay. I did say this was harder than it looked. Do we have any apologies for absence?
We have apologies from Robert Parks, who's our lay member and Chair of Audit. We have apologies from Crystal Oldman, who's our registered nurse lay member on the governing body. And we have apologies from Louise Smith, who I'm not quite sure exactly what her revised title is, if it has changed, working on the COVID-19 vaccine, but otherwise it's Interim Director of Primary Care and Transformation.
Thank you. Do we have any declarations of interest pertinent to the agenda items? I would like to declare an item, I think with my GP colleagues, for item 14. Do we have any additional declarations of interest?
None that I'm aware of, Chair, for decisions that are on the agenda. Forgive the typo at the top of the agenda where the declarations refers to item 15 when in fact it should say item 14.
And I will specifically ask for any declarations of gifts or hospitality. Thank you. Could we therefore review and hopefully approve the minutes of the meeting held on the 10th of September for accuracy?
Just
Robert, yes.
Yeah, a couple of me. So on page 6, on item 4, it says CCG replied. I think it was meant to be CC, which is Caroline Capel.
Yes.
Similarly, on top of page 9, it's KJ. I think that was meant to be James, the JK.
Yeah. Okay. I'll amend those points.
Any other comments? Could we approve those minutes then, please? Picking up the action log, there are 2 actions. The first is about the equality impact assessment of COVID-19. That it remains an open action. Do we have any further information about the timing of when that review will take place? I'm just looking towards Karen here.
No, we don't have a timing of the review. There's obviously quite a lot of stuff coming out nationally anyway at the moment. But yeah, we're too busy at the moment trying to get through phase 2, I must admit.
Thank you very much. Understandable. And the second action was around VTE, venous thrombus embolus, and that's a closed action. Which brings us on to the Accountable Officer and Deputy Accountable Officer's report.
Raj, thank you. Good morning, everyone. I will cover off all the items except for 2 and 6, which I'll pass to Robert for. So first, obviously, the majority of time over the last month has been spent preparing for sort of wave 2 of COVID, and we will cover that off on a later agenda item. But I'll cover through how we're structuring to respond to the incident. Item 2, Robert will come back to. On the winter plan, we submitted a winter plan for Buckinghamshire as a place jointly with the local authority. The draft version of that plan was described as being accurate with all the right components, but required further analytics to be put underneath, which we subsequently did. The revised plan was put back. Actually, was put back up. I had feedback, positive feedback, and we are green or amber green rated in all elements of that plan from NHS England. At the system leaders group, we essentially worked our way through essentially what Anne Eden has described as the triple aim of managing COVID wave 2, winter and flu, and protecting planned care. We also we talked through that as the activity. We've also had various submissions around the financial submission for the system, which is currently we are still at a system 37 million in deficit, but we are working through some allowable overruns with the with NHS England, so we're not at a final point of knowing exactly what our budget items we're aiming for. The other piece, we also submitted our draft COVID vaccination plans. Again, you'll be aware this is a rapidly evolving space. As vaccines becomes clear, they're going to become available, and we're clear what we are trying to, the mass vaccination we're trying to sort of set up and work towards. In primary care, just to note that we are looking to try and see if we can get better capture of capacity and demand in primary care, and there's work ongoing in a variety of places we're joining up, including with the LMC, on how to use some of the EMIS records and entries as a way of measuring sort of encounters and workload, which, if we could get right, I think would be enormously valuable, both for strategic planning and resource planning. So we're sort of working our way through on that. So that's all I wanted to update on. Happy to take other questions, but I suggest, Robert, do you want to just cover off 2 and 6, and then we pause for questions at that point?
Yeah, happy to, James. So 2 contains the update in terms of the things that the ICP Partnership Board has been discussing. A number of these are updated on the governing body agenda today, including the phase 3 recovery and the winter plan, and also the Healthier Lives is the update to Health and Wellbeing Board strategy that's been out for engagement and previously came to governing body. We had a session yesterday across the system to look at sort of what the early sort of actions would be to take that forward, and that'll be coming back to the Health and Wellbeing Board on the 10th of December. So obviously the focus around the integrated partnership is, particularly over the last few months, has been around restoration, which obviously we can cover later on the agenda. And the final thing for me was their update in terms of intermediate contracts for intermediate services. These are services that are sort of sit between the sort of referral on from primary care, but not into sort of for acute services. We've got a number of those contracts that are due to expire at the end of this financial year, and we are proposing through a sort of single tender waiver process that we will extend a number of those for sort of further 1+1 year to allow sort of process to go through with in terms of procurement for those, but just recognising the sort of capacity in the system to both put out and respond to procurements. We're proposing to extend those post March.
Thank you, Robert. Can I invite any questions on the AO report? Graham.
Hi, yes. It's under primary care. It says about half of the appointments are face to face. This year, one of the biggest revelations I've had is how digitally illiterate some people are. Do we have any idea about, especially as Buckinghamshire is quite an elderly population, how many people may be slipping through the net, as it were?
So a couple of things on that, Graham. First is we are working with Health Watch, who are looking at this space for us across the whole system in terms of whether the shift to digital is leaving folks behind, which I think is exactly the question you're asking. I don't at this point have the timeframes on that, but we are looking for them to leverage the work that they're doing. The second is to be clear that within primary care, we are making sure there is a selection of channels. So it's not that we are sort of forcing people through a digital channel either as people or for any specific conditions, but we are making sure that it's available and smooth for those who wish to do it. I think others will be able to comment, but I also think it's quite interesting that still is settling down with switches from, I think, quite initially to video, now switching back across to phone. There's quite there's a balancing that's going through, as well as people getting more comfortable with some of the online triage. So I think it's a space we need to watch. It's working its way through. We're definitely not trying to sort of force people down that direction, but it's a good check and balance, and Health Watch is the process we wanted to use to try and do that.
Okay, thank you.
I do think that's a great question. It's something we should revisit from time to time to make sure that developments aren't leaving some of our most vulnerable behind. I think it was Robin next.
Can I just ask the other half of Graham's question, which is, do we have patient-reported outcomes from these digital consultations, which I think are a great thing and which we must really cherish and drive forward? But do we know what the folk think?
So,
okay, I'll let Robert.
Yeah, just to say, we did ask that type of question through the ICP engagement process we've just been running, which has just closed, Robin. So that's just been sort of collated and summarised, and obviously we discussed ICP. So I think as we go through that process again, we'll have some further information in terms of, like I say, what people think, what the public think around that. So, but we did include that in the engagement we've just run.
Neil, were you responding to this particular item?
Yeah, it was just to add a little bit more to Robert's comments as well, that within particularly BHT, we're also working with them to develop actual capturing of outcomes for patients as well. It's not set up yet, but it certainly is in motion to get ready so we can start using it.
I have certainly seen some feedback from within BHT about how their digital outpatients and virtual outpatients have been received by a selection of their patients. Tony.
Just a quick question on intermediate services, the contracts. Have we assessed the potential for challenges on those extensions?
I don't know if Neil, you might want to come in on that.
Yeah, hi Tony. Yeah, we've liaised with providers and with the CSU and with procurement team on that. They've advised that it is low risk. There is always a risk. That's the frank nature of it, but we deem it low because they're established. They've provided all those services for quite a long time now. The fact that we have a plan in place to recommission them, we've got a phased way over the next sort of 2 years to do that, I think would be able to push back on any challenge if we were to sort of go down that route, but we do deem it low risk.
Okay, thank you.
Apologies, Neil, as this is a public meeting, could I ask you to introduce yourself, because I forgot to do so at the beginning.
No, very sorry. Quite right. It's good afternoon, morning. Oh, catch up, Neil. Good morning, everybody. Neil Flint, Head of Commission for Plan Care, and working with Robert within the ICP to support recovery.
Thank you very much. Can we close the item for the AO report? Which gives us 15 minutes to cover James's next item, which is the Wave 2 preparation. And James does have to leave at 11 to attend an important regional call. James.
Thank you, Raj. So let me just describe what we're putting in place for Wave 2. I think the first thing I would say is that Wave 2 feels different. It is coming at us more slowly than Wave 1, and we feel better prepared, having been through it before, but also we've got good PPE stock, both nationally and local buffer stock that we can leverage. And for the plan care, we have the independent sector arrangements both sort of in place and working. So in that sense, it feels better. We have the COVID will be managed as an incident, and therefore we're required to set up an incident control centre. Now, in fact, this incident, we will manage COVID, winter, and any issues that arise from us leaving the transitional period with EU will all get managed through the same incident. We have a incident director, Volker Kellerman, who is on secondment from SCAS running that incident centre. But we have moved about 20 CCG staff from across the 3 CCGs in to support that centre. So I think one of the learnings from Wave 1, we did not really have resilience in that centre. So Volker at one point was on a 1-in-1 for many weeks, and we put in some deputies to Volker, as well as a team that can actually support. During the peak of Wave 1, that incident centre managed about 300 to 500 inquiries a day in terms of requests for information, chasing information, requests to distribute information, and the follow-up that goes with that. So it's quite an intensive set of processes. Supporting the incident then are a number of teams that operate at system level and at place level. At system level, we have four main cells. The first is around capacity planning and escalation. This is to make sure that we are aware across the system if we are starting to run out of intensive care, oxygen, or other capacities, and there is processes in place from Wave 1 around mutual aid to support that. There is also this time an escalation process that the region will want to sign off if we plan to step down any planned care services as a mechanism to make sure we remain focused on both COVID, urgent care, and planned care. So in other words, we're trying not to step down any of the planned care unless absolutely necessary. There is a second team being headed up by Louise Smith, which is around putting in place plans for the mass vaccination programme that will follow the arrival of a COVID-19 vaccine, which obviously is working across with providers, primary care, but there will also be additional, as we move down cohorts that we don't normally vaccinate, we'll move down into other mechanisms and resources to try and execute. PPE and supplies, as I say, we're in better shape on PPE. We are cognizant that supplies could be a bigger disruption depending on where we end up in regarding deals with the European Union, and obviously there's a communication cell working actively to try and make sure that all of this gets distributed across both internally and externally. A couple of other things to just flag at place level, set of teams that essentially a lot of these are business as usual teams moved into sort of more operational focus with a different cadence of sort of input and escalation. Some of those teams are effectively run by health, but others are run by local authority. There's quite a joint mechanism in place. There are currently twice weekly, and they will, if we need to, will be more frequent meetings of the leaders across place, which includes myself and Robert, but also Neil MacDonald and Rachel Shimon from the council. Across system, we have for mutual aid, I meet with the chief executives on twice weekly to confirm any mutual aid or any issues that are sort of moving forward. So it feels that in many ways we feel better prepared. This thing is coming at us more slowly. That said, it is a greater challenge because the seasons are against us, and winter is normally a challenge. And we've obviously got this triple aim of both managing winter, COVID, and the transition. And the final piece, which we are cognizant on but not yet solved, which is the staff. Many of our frontline staff are still, to an extent, tired from the first wave, and this is quite a challenge as we head into this with winter to follow, and we're trying to work out how to step up the sort of health, well-being and care for particularly the frontline staff. Not all the way through on that, but we're cognizant of it. So let me just pause at that point. I'm very happy to take any questions.
Robin.
Yeah, hi. That's, I mean, good stuff, James, and thank you very much indeed. I suppose one of the things I'm interested in is just and I was just talking briefly about it before with Raj, is of course that the flu staff seems not to be terribly active at this point, and it may be that the social distancing that's going on is actually really effective for flu because it's so somewhat less infectious. I want to just ask a bit about the flexibility of the triple aim. Triple aim, great thing, isn't it? The flexibility of the triple aim and making sure that we don't push too much resource into the emergency unpredictable stuff, and that we do manage to soak up the business as usual activity, which of course is what's dropped in with wave one.
I think it's a very good question, Robin. You're right. The triple. I think the way I would interpret the triple aim at its simplest level is a way of being absolutely crystal clear that we're not approaching wave two as we approach wave one. So wave one was very much, drop everything and focus on what was coming at us that we'd never seen before, and quite rapidly. For some of the reasons I've outlined, that's not the case now, and therefore there is obviously pressure to maintain the sort of planned care work. I think to be clear, urgent and cancer work continued through wave one, and obviously will continue through wave two. And I think we have good tracking mechanisms in secondary care to make sure that's the case. I also think we have relatively, reasonably robust processes around keeping green sites and using the independent sector to maintain some of the planned care. My worries, if I was to be honest, are twofold. One is what we don't know is what we will run out of. So, for example, if we find we have a lot of patients on critical care, we may be short of anaesthetists, even though we've got spare theatres in independent sectors. So there is that's why that capacity escalation cell has to balance a number of different areas to make those decisions. That's, we're obviously trying to do our best on staffing, but if, for example, flu did pick up, or norovirus picked up, or COVID picked, we started to get staff impacted. So you've got reduction in the labour force, as well as high rates. We could see ourselves, that's the reason for putting the mutual aid in. So that's one piece we're cognizant on, and that's why those capacity escalation calls, which involve the coups from each of the three hospitals, are in place, and would be at that level in place every day. I think the second thing, which is still to work through, is actually primary care, because we will be leaning, I think, quite heavily on primary care in terms of the COVID vaccine. And again, the timing of that is not absolutely certain. And that may require, or that is likely to sort of compress the ability of primary care to continue doing its more screening and planned sort of activities. And that we still have to work our way through, Robin. So I think, and then obviously there's less metrics in that space. So to be perfectly frank, that's, while I think we're in, much better shape than we obviously were in wave one, it's not a walk in the park.
Robin, yeah, did you have a comment before I bring?
Yeah, sorry, that's really helpful, James, and very clear, and thank you for that. One of the things that comes up in the quality performance report is the diagnostics and the wait for diagnostics, the 60, I can't think what's called the metric that there is. The 6 weeks thing, and that's of course a lead-in for a lot of the cancer and emergency work, and that completely sunk when with wave one, and it's a bit better now, but it's still pretty awful. And I'm sort of really gravely concerned about that metric, and wanting to, I would be really keen to be assured that there were, and I don't know why I'm asking this, but that we're sort of focused on it, and that, because I think it is a really important way of looking at cancer pathways and stuff, as well as yeah.
Yes, I think so you are the cancer pathway weights did rise through to about June, and then started to fall, and have been falling since. So I think we are on it. We are trying to sort of work through, but you're right. We have capacity constraints in the diagnostics, and the PPE does slow things slow through the capacities. But I think those, I can double check and come back to you, Robin, but I think even both in Bucks and across the system, that we are improving performance on the sort of cancer weights. I think our challenge in the last month or so is actually the 2-week rates have been rising, actually, as the referral rates have been rising, which in many ways may be a good thing, or maybe it's the backlog that's coming back out of primary care. So we've got rising demand, but we are still keeping, and the waiting times are falling, but they're not, as you say, they're not where they should be. We've still got catch up to do. But
Robin speaks to the broader point, which is to retain the focus of the impact on patients. And I think in the first wave, we were quite good at keeping focus on a piece of work that was called clinical harms. And I think it's going to be important that we retain our focus on that over the next few months. And hopefully that's something that the quality committee can keep a sharp handle on. Thank you, Robin. Graham.
This may be a question for an epidemiologist. Why is it not so harsh this time? Is it because we know the illness better, or is it a slightly different strain? Why is it? We just know more about this virus now. Why is it not as harsh?
So if I could split the question into 2 parts, Graham. One part I know the answer to, and one part I don't know the answer to. So the part I know the answer to is once people are in hospital, our ability to, when you speak to the intensive care docs, they will say, we know a darn sight more about this thing now than we ever knew right back at the beginning of March. We know how to treat it. We've got different regimes. The number of people going into intensive care is less than before. The use of CPAP is greater, and the national statistics are showing that the sort of death rates once you are admitted to hospital are lower in this wave than they were in the previous wave, and those 2 things we believe are linked. In other words, we know better how to do it. The second part of your question, which is, why are we in a different place than the northwest, and to a certain extent the doubling times are longer at this point than I think we might have predicted even 2, 3, 4 weeks ago. Don't know whether that's our social distancing, whether it's the lockdown, whether we're not sure, whether we don't really know how many people have really had it, and we're starting to get bits of herd immunity. That's an epidemiology question. I suspect we won't know the answer for that for many months. But you're right, it is. We have, I think 2 or 3 weeks ago, we thought we would have far more folks being admitted than we currently have in the southeast.
Thank you.
An interesting observation was that the areas most severely affected now were those less affected by the first wave, and vice versa. Now, no one quite knows why that association is, but it may be something to do with behaviours or social behaviours as a result of being affected first time, or not being affected severely first time. Any other questions for James before he takes his... Oh, Graham, is that an old hand?
That's an old hand, sorry.
Okay, James, I think that gives you a minute and a half to rest before your next meeting.
Apologies, Annie. Apologies for the clash, but thank you. Appreciate it.
Thank you very much. If we could go back to the insurance section of the meeting, and Russell, a review of the governing body assurance framework.
Yeah, so you've got a set of summary slides that highlights the highest scoring risks as they are at the moment, split as on previous occasions between the BAF and business as usual, corporate risk register risks, and COVID specific risk register risks. Nothing specific to say on the BAF other than what is already reported, and the second of the slides gives a summary position on where we are, and particularly, of course, around the financial implications of where we are. Kate will cover more off on the standing agenda item later on. In terms of the corporate risk register business as usual highlights, one of the risks that's on there is in relation to GPIT and the reduction in the available GPIT capital due to COVID costs being transferred by NHSE to in-year budgets. Robert, Magilton, I don't know if you have any more information than what I might have as to where we are at on that risk and the gap in the shortfall in the in-year funding.
Yeah, I'm not sure Kate chip in. So we've had the PID approved for money that we've already spent, but no additional money yet to come in. So it's still a risk. It's about 900,000, and I think it leaves us about sort of 100 and just under 150,000 left on GP capital. So we've raised it a number of times, but I'm sure Kate can give the latest position.
Yeah, absolutely, Robert. So yeah, as you say, we've had the PID approved, but it has gone against business as usual capital, so it's taken the majority of that. So that does give us only 139,000, as Robert alluded to implement Windows 10 N365 and our normal MIG. So we are pushing back quite heavily on that, or continue to push back quite heavily on that, to make sure that we get that funding through, because those are projects that we do need to continue with.
Kate, could you just expand on what a PID and a MIG is for those who may not know?
Sorry, a project initiation document. So that's the document supporting the spend in capital, and the MIG is the minor improvement grants for primary care. So that covers off things like infection control, etc., where we support practices to take those forward. Thank you.
Do we have any questions or comments about the governance documents that have been presented for governing body, and whether we believe them to be a fair and accurate representation of our current state, given the uncertainty of where we are? Thank you. Was there anything else you needed to say on this item, Russell?
I don't think so. All the other information that you've got there is as it is at the moment. And in relation to COVID specific risks, again, the majority of the challenges and the highest scoring risks are those around COVID costs, impact driving growth, and the phase 3 allocation, the details that we largely already know. And if there are any specific changes in respect of that, I'm sure Kate again will pick that up under the finance item later on the agenda.
Okay, great, thank you. In which case I'd like to welcome Caroline Capel, who's joined us, the ICP Director of Urgent Care, who's going to talk to us and show us a presentation on winter planning and flu.
Thank you, Raj. Hello, everybody. So I'm just going to take you through an update on where we are with the delivery of our winter plan, and also across Buckinghamshire where we are with our flu vaccination programme. Just wait for the slides.
For some reason, I don't know why, my version of Teams doesn't want to show the one that I've got the slides open, but it's not showing the prompt on Teams. So bear with me 1 second. Oh, there we go. Got it now. Yeah, there we are.
Excellent. Thank you, Russell. Okay, so if you just go to the next slide. Okay, so just setting the context around our winter delivery plan, which I presented, I believe, last month as the final version of the Buckinghamshire system-wide winter plan. We are focusing this on 5 key outcomes, and as we go through the actions through the plan, is making sure we maintain those principles going forward. The first one being around the patient outcomes and make sure that we're delivering safe and effective care. Prevention, so very much around the kind of self-care and prevention programme, and making sure that's maintained throughout the winter period, and in particular around our patient and staff protection through the COVID pandemic, and then also make sure that we avoid tenancies in the acute setting, making sure that patients are able to go to the right place at the right time and not necessarily always having to be presenting at our emergency department, and then admissions, placing patients in the right place at the right time as well, and then enabling rapid discharge so that patients are only in a hospital bed or community hospital bed as and when they need to. Just go to the next slide, and I'll just go through some areas of focus that we have been completing over the last since I last presented to yourselves here. So we had a week on the 12th of October where we had what we called Project Butterfly, and what this was very much around testing our winter plans, being able to use the week as an opportunity across the whole Buckinghamshire system to develop our steps and processes that were within the winter action plan, and also our transformation and restoration programme for urgent and emergency care. So that week went really well, and what we are doing is having a second follow-up week on the 30th of November in order to make sure that we're maintaining the changes that we put forward during that week and being able to test new models of carers at the same time. One of those new models of care was the Think 111 First programme, and that is where we now directly book from 111 into our emergency department. This has been running since the 12th of October, and it's been relatively successful. We now offer 16 appointment slots per day. What that means is that patients who ring 111 will go through a clinical assessment pathway. If the outcome is for them to be attending the emergency department, that will be revalidated by a GP, and then if the outcome is that they still do need to be seen in the emergency department, then they could potentially be booked into an appointment slot. So that is now in place to support our winter period. The next one is around the implementation of our restore in nursing homes and our residential homes, and that's continuing, and in fact that is now across most of our homes in Buckinghamshire. As part of the standing back up of the elective care, we now have extensive patient swabbing. So prior to an elective operation, patients will be swabbed for COVID 3 days before they then have their surgery. And we now have sites across Stoke Mandeville Hospital and Wickham to help support that. We've been working very closely with our colleagues from FedBucks on making sure that we maintain through the winter period some specific clinics to help our primary care colleagues, but also our patient population that may need to be seen face to face in a different setting. And then the working with our Oxford Health colleagues, we do have in place 24/7 mental health lines, and that will continue through the winter period. That was set up during the COVID pandemic, and that will continue to help through the winter. And then alongside that, we then have the crisis and community mental health services in place as well, with a focus on early discharge to help the acute trust. Next slide. So just going through where we are at with flu. So our flu programme is in conjunction with our Berkshire, West and Oxfordshire colleagues, alongside having a very focused place-based approach at the same time. So the data provided here is for week 43, which was 25th of October. I have this week's data as well, so just to kind of highlight that it is increasing on a week by week basis. So our over 65s is now at just under 70%, and our age 2s is now at 49%, age 3 50%. Our vulnerable has gone up to 32%, and our pregnant vaccinations are now at 22%. In order to continue to increase that, we are doing some targeted communication and engagement with those key cohorts to help increase the vaccination take up. So it is improving, and it is continues to do so. And then if you just go to the next slide. So one of the things that we have across Buckinghamshire, and I'm sure that's been picked up, is around our second surge planning. We have an approach that is across the whole of Buckinghamshire, and then also at the local provider level. So in the hospitals, we have a second surge plan that will go into the level of detail on how we manage each of our wards and our ITU, etc. And then we also have a plan that helps support the whole of Buckinghamshire. We have a trigger response plan, so as we reach certain triggers, there will be an expectation of actions to be implemented across our system, and then the impact and implications of that that wider. So working very collectively together to be able to support that. Each of those 3 areas are managed and monitored via our urgent and emergency care board, which meets on a monthly basis, which is our whole system. So to provide that assurance that the whole system is working together to deliver on these 3 key areas this winter. And I welcome any questions.
Thank you, Caroline, for that very clear and very comprehensive update and report. Any questions? I cannot see the hands. Whoever that is, please speak. Tony.
We were told at Finance Committee that there is an issue about discharge of COVID patients to care homes, in the sense that the care homes no longer want to take them, and that a facility was going to be provided at Beaconsfield with I think 15 beds in it, to deal with that problem. Can you give us an update on where we are with that?
Yes, so we are not looking at Beaconsfield now, so we are looking at an alternative solution, and hopefully by the end of the week we will have that in place. So you are right, what happens is if a patient is still positive but medically fit to enable discharge from the hospital, a care home won't take them back until we actually are able to provide a negative result. Sorry. So at the moment, typical, isn't it, when you have a dog? So at the moment we are just working through an alternative solution for that. There are issues like being able to make sure that we can staff the facility and make IPC protection in place as well. So hopefully towards the end of the week we'll be able to share that model and where we will be to support that pathway.
Thank you. Thank you.
And it is my understanding there have been some very productive discussions within the ICP around that in recent days.
Absolutely, it's progressing at pace and we will have a solution by Friday.
Right. Graham.
Following up something Robin said earlier, so as the population are all wearing face masks, I'm not sure about the efficacy of that, and flu's not as contagious, I don't think, as COVID, and there's been social distancing. Is there a chance that incidences of flu will drop dramatically this year?
I mean, I would welcome a clinical view of that response if Raj would like to comment. But we would expect just an example, flu, the R rate of flu is about 5 compared to COVID, which is 1.4 or 1.3 at the moment. So actually it does spread quicker, and we would expect the use of masks, social distancing and all of those measures in place to actually have an impact on flu. At the moment, as it is November, we would have expected more cases in the hospital, and we have seen quite a reduction. So at the moment, the weather may contribute to that, so it's difficult to tell whether it is the measures that we have in place for COVID is having an impact on the acute attendances. I don't know if anybody else.
I suppose it's a good scientific experiment to see the efficacy of social distancing and face masks, to see how flu manifests itself this year.
Absolutely.
I mean, certainly there was data from, I think, 1,500 sentinel practices in England about 10 days ago that showed that circulating flu levels were about 2% of what we'd normally expect at this time of year. Now, no one quite can explain why that might be. Certainly from a clinical point of view, I've seen minimal instances of patients reporting flu-like symptoms over the last couple of weeks, whereas normally you'd expect that to be filtering through. Again, I'll expand this topic out to my clinical colleagues and maybe ask for Dal's opinion in the first instance, and then other clinical colleagues to see what they're experiencing at practice level.
Yes, thank you. I think some of the knowledge and experience we're going to have is from the Southern Hemisphere and what happened in Australia, and they did see lower cases. Reading something in the BMJ, I think last week, whether we can extrapolate that data, whether we've got the same strains, whether our social distancing and the way our public are behaving is going to have an impact on that. I think we're certainly going to see less cases, but how similar our experience is going to be to the Southern Hemisphere, we're not sure.
And for clinical colleagues, in terms of your experiences at practice level when you're duty doctoring or triaging?
Yeah, definitely seeing a decreased amount of flu coming through, without a doubt, which is not surprising given the measures in place currently, I would suggest.
I mean, that would be a very helpful
outcome. No difference.
I mean, normally we'd be experiencing several people a day phoning up with flu-like symptoms, wanting to be seen, wanting advice, and I haven't come across that.
We'll have to be careful, otherwise we're going to lock down and wear masks indefinitely.
I mean, we could certainly do with the extra help that a very low flu impact would have on services this year. That would be a real benefit. Any other questions for Caroline? Dal?
Only just to note that the uptake in certain groups has been better. So pregnant women, we've seen increased rates of uptake, and that's partly been with support from our trust proactively vaccinating that group. So I wonder whether some of the impact may be more people proactively seeking the flu vaccine as well. That's going to impact what we see this year.
The number struck me as low. So is this an improvement on historic uptake amongst that group?
So in that pregnant cohort, yes.
Okay. Any final questions? Otherwise, thank you very much, Caroline, and the very best of luck over the next few weeks.
Thank you very much, everybody. Thank you.
Thank you for joining us. Which brings us on to item 10, which is restoration and recovery. Phase 3. Neil, I think you're down for this.
Yes, good morning, everybody. The slide pack was issued out. I'll just bring it up if you bear with me 2 seconds. The fact that you've had a chance to see it, I'm confident that I won't have to go through it quite to the same degree as I've done on previous months. But what I'll do is hopefully you can all see that now. Raj, if I could trouble you to let me know if anybody has any questions as we run through it, because I can't see if hands go up. Is that all right?
Happy to.
Okay, my battery is running low apparently, which I'm sure you didn't all need to see, but there we go. Right, I was a lot more organised a few minutes ago. Right, let me go back up to the start. So first off, so this is the ICP report. It is being circulated across a number of boards at the moment. And it continues to be developed. We've got the general overview status here. I'm not going to go into urgent emergency care because Caroline's just done a wonderful job and articulated it far better than I could. But as you can see from here, there's just a few things which I'll tease out as we go through the slides, really around elective care. That's currently got an amber status, mainly because of diagnostics capacity, along with the ask from NHS England to meet their trajectory. We are slightly behind, but hopefully that's not news to you because we've been talking about it sort of every week so far. But we are improving in that trajectory. And it's fair to say that we never said to NHS England that we would absolutely meet their ask, but we would get as close as we could to it. With primary care, probably yourself, Raj, and colleagues on the call could talk about more of the challenges that you're facing, but this is really around the current demand that's coming through, which is fairly significant. So your ability to recover services and restore them is becoming a significant challenge, along with because of COVID, being able to establish PCNs in quite the way and at the pace that was originally sort of desired.
Can I pause there and invite Rashmi from a busy practice and from a PCN perspective to just give your brief input?
Please.
So I think the referrals had dropped off purely because people were scared to come to their GPs or contact GPs earlier on. Things have changed, things are presenting, people are presenting with issues. So referral rates have definitely gone up, patient contact has definitely gone up. And which is why you're probably seeing this pent-up demand from the first lockdown.
And in terms of kind of work with PCNs who themselves are busy at practice level?
I think the PCNs are very busy, practices are very busy. And earlier when we had a conversation about digital, actually the advantage of having digital has been that we've been able to give more time to our patients with multimorbidities and comorbidities and be able to do that because we've been able to lengthen times, but certainly practices are extremely busy at the moment with, and are encouraging patients to make contact, you know, whether it is via phone or video consultations or face to face, but certainly things are a lot different to how they were.
And certainly all the data that we've got suggests that primary care is actually busier and processing more activity now than it was certainly in January of this year and comparable periods last year.
Definitely.
Thank you. Please continue.
Brilliant. And thank you, Rashmi. Yeah, community care, again, that's at an amber status. That's heavily impacted because of a flood at one of the facilities, which affected podiatry services and has seen an increase in a waiting list there. They are starting to get back through that, but it has impacted sort of on their recovery of services as well. And then mental health, again, I'll draw your attention to that. That's at an amber status. Partly because, again, demand for them is increasing. They are able to meet that demand, but really this more relates to some of the targets that they've either been set for things like learning disability health checks. There is a national target, and locally we set a slightly lower target. So it's scored as amber because we're not going to get that national target, but we are on track to meet the local one that was set. So they're kind of the main bits which I'll draw your attention to. But as you can see, the rest is green. For those of you that aren't too familiar on what each of the groups is trying to do, we've started to introduce a bit of a summary slide just to be able to go through that. So I'll let you peruse that at your own leisure. And then we started to pick out in between the different areas where we are in terms of the NHS England phase 3 requirements and the progress on those. Again, as with last month, it's fair to say that we are absolutely on, everything is started. So we're confident that we're going to deliver what we said. There's a few deadlines coming up through each of the task and finish groups to make sure that we've got track of them and the assurances in place. The bit which we're probably struggling a little bit is where we've got some of the asks are more at a ICS level or even from NHS England, where we've got things like recovery of community pharmacists, which is commissioned by NHS England. So it sits on our plan, but actually there's very little we can do about it. So they're just some areas which we struggle with sight on. We're also looking going forward about having some to capture some of the social care work that's going on as well. So we've got whole system sites for both health and social care. That way we can start to see some for our interdependencies and join things up a lot better. As I said, I wouldn't necessarily go through the urgent care slides. Caroline's just touched through that, but you can sort of see those trends of emergency department activity. Elective care, as I touched on, the main issues here are really around sort of diagnostic capacity, which is a struggle. It's been an ongoing issue. It's a regional and a national one. There is a task and finish group set up to look at this. One of our independent providers anticipated they could do a little bit more diagnostics, particularly some MRI scans, but we're unable to fulfill that. So we're continuing to work and identify the partners that can help with that. The main issue, the main services really affecting performance on this will be no surprises to most, which is ophthalmology and trauma and orthopedics. There have always been areas of significant demand, but they seem to be driving high waiting lists, and they align with the 52-week waits as well. So the highest volume of 52 weeks that we're seeing relate to those two services. In terms of our delivery against the trajectory, as you can see from that graph, there's another one further down. We are starting to get closer towards our plan. We're about 5% away. So I think this graph will show about 70% against last year's plan. But we are, as I've just sort of seen this morning, we're at 75%. So every few weeks we're creeping up and we're getting closer. A large part of the reason that we're not able to fulfill that requirement at the moment is down to some of our independent sector activity. So we had anticipated, whilst working with BMI Shelburne, to have a third theatre come online to take our total capacity up to 10. Because of capital and remedial works, that was delayed. It's come on live. It's come online now, so it's up and running, but it just meant that there was a delay in terms of where we thought we would be. As I mentioned with the community work, at the Brookside Clinic, which is in Aylesbury, there was a flood which significantly affected their podiatry services, and that's why you can see particularly the current waiting list for podiatry far exceed all others. So they're trying to recover that, but it is going to be a bit of a slow process, but they're not highlighting any other concerns apart from that I feel we need to flag up. Rashmi just particularly talked about primary care, so I don't aim to go through anything further on that. As I touched on mental health, there's quite a lot going off. As I highlighted, the main things around their AMBER status is predominantly down to sort of self locally set targets, which they are meeting, but that doesn't compare with national ones. Overall, their demand is increasing. Interestingly, from everywhere else, we're seeing quite a good move towards the virtual appointments from face to face. We have seen the uptake, and there are key services such as the dementia screening, which have now got online virtual assessments, which is good. We are starting to get hints from some of the services that there is some they are reverting back in some cases to face, and the ratio starting to switch again. And obviously with the second wave, that starts to cause a few more issues. So again, that's why for many of the services that they do have some struggles there. But things like IAPT, Healthy Mind, and that I continue to sort of see a lot of virtual activity, which is helping to sort of mitigate some of that. And the main bit is for those in crisis, there is a 24/7 line, there are care plans in place, and there does seem to be the strong links between the primary care, the mental health providers, and the police and the BHT to sort of coordinate any such crisis. I think those at higher risk who have the network there, it's whether they then utilise it. And then the infrastructure group, there's quite a lot going off through here, and this is quite a large programme because it's anything from physical estates, how that's being developed, through to human resources and communication. HR, the human resources, I think would probably be the highest risk that most would say at the moment. I know it's not quite scored in the same way there, but actually continuing to operate at the same levels whilst you retain a risk of staff going off either with symptoms or because of isolation or because of caring for another during this next sort of period remains quite a considerable risk. Comms with patients seems to be improving. We're seeing less complaints coming through PALS at the moment. So although they're getting high volumes, it seems to have started going the other way. We'd like to think that's because we're starting to, or BHT is starting to send out direct letters around to patients around delayed appointments, which we're confident starting to address that. We know there's still work to go, but we think that that initial communication has helped start to reduce some of those complaints coming in. We've also started to try and capture, which hopefully some of this will be very familiar to Rashmi. Apologies, some of it's copy and paste from her and Simon's work, but we're trying to make sure that really through every work stream and every feed, we're identifying any work that's trying and seeking to address inequalities, make sure it becomes a golden thread through everything. So we've asked each of the work streams to start identifying work that they have done or plan to do, which we can have a bit of a stock take, but also then seek to identify any gaps and any further work that we need to do. Because Steve Goldsmith has now been appointed to sort of work with Rashmi and work on inequalities, I'll be linking with him going forward, and hopefully we'll start to provide a bit more information on this, and you'll start to get a bit more updates on what we're particularly doing and any key initiatives that we can refer to, basically to test out.
Neil, can I just pause you there, because I think Kim's posted a question around the communications team referred to. Kim, would you like to articulate that?
Yeah, I just wanted to double check that. So on the infrastructure slide where it mentions that the communications team sits as AMBER, that's BHT's team, or is it the communications teams as a whole in the system?
It's a collective as a whole in the system. I think. And speaking to David Williams particularly around that, because we've had queries in the past about how joined up CCG Comms is along with BHT. I think those links are there now. There is definitely probably still a bit of work to be done, but because there are still complaints coming through, there are still challenges to communication at the moment, whether it's one party or another. But it's definitely feeling like it's more of a collective one that was assessed to be an AMBER status, because there's still improvements to be made.
And sorry, just as a follow-up, how does that get articulated across the system, so that we are aware that there is a challenge in that specific area, or perceived challenge in that area?
There's a couple of ways. So we have a fortnightly recovery group which has communications colleagues on. At that, we push for an update from them on it, but also take back to each of the groups and working groups to engage with communication leads from the whole of the system to be able to sort of take that forward. But hopefully you'll see towards the end of this slide pack there is quite a lot of work which is now being captured around communications, which has either been done or in progress. So this again, we want to start to use this pack to help inform and share that across the system so everybody is aware of what's being done, and then we can start to join it up a little better.
Neil, is it possible to just link Kim into some of that work and get her cited on it, because Kim's a key link for us when we meet as a CCG and discuss primary care and wider issues. So it'd be really helpful for her to be cited on that work if possible.
Completely agree, and I'd sort of then reflect David Williams from CCG. He's constantly driving at this, that it needs to join up probably a lot better, from rather than just be seen as BHT leading on a set of work, how it all comes together, particularly with Kim and our comms. So I completely support and we'll work with Kim on that.
Brilliant. And I think Rashmi had a comment.
So I just wanted to add to the inequalities slide that there is a key piece of work with the population health management action learning sets across the ICS as well as the PCNs. And as part of that, 3 of our PCNs participating have been looking at their data and have identified some key projects upon the data they've looked at in deprivation. So Signet PCN is looking at people with severe mental illness and deprivation. Mid-Chilterns is looking at heart failure, and the ARC PCN is looking at social deprivation in people with multiple comorbidities. So that is a great piece of work going on across those 3 PCNs, and going forward, this is going to be offered to all the PCNs in Buckinghamshire CCG. And also as an ICS, we had submitted a bid for a project for cardiovascular management linked with deprivation, and so it would go through the whole process of, what can we do for prevention management and preventing complications. So that is going to be starting fairly soon.
Brilliant. Neil, just before we move on the slides you've got on, I'm just looking at the gambling part of that table, and I'm just wondering whether we might want to rephrase that section, just as these documents sometimes go into the public domain.
Yeah, I think it's probably a fair point. Like I say, with Steve picking this up and working with Rashmi going forward, we'll look at what's phrased, how it's captured going forward.
Thank you very much. Please proceed.
Brilliant, thank you. So always the lovely stuff, things like performance. As I sort of talked before, this will give you a status. At the moment, we're still reflecting BHT, but we now have the CS3 running in parallel overall system position. So what you're about to see is particularly BHT's data, which is obviously about 60% of our overall activity for patients, but we do expect for next month to have an overall CCG position set against that as well. I've already talked about the phase 3 requirements, and you just got a bit of an overview of how we're getting on there. But as I sort of mentioned earlier, we are seeing with elective and outpatient cases, they are getting closer towards our trajectory and closer towards our plan. As I mentioned, particularly with the elective and day cases, we have just had new data through which shows we're on 70% compared to last year. We are about 75% this month, so that's improved further and getting closer towards our trajectory. And I already outlined the reasons why we're a little bit behind plan there. With outpatients, I've just had an update as well, which actually shows us sort of staying static through October at around 83% compared to last year as well. That's a bit of a mixture of case mix rather than anything else. But I do need to work with the team to understand that a little bit more, so I'll be able to provide more updates next month. Of most significance is really, and for us to be flagged towards, is our 52-week wait. So as I mentioned earlier, the 2 biggest contributors to that are the waiting list within orthopaedics and ophthalmology. So what are we doing about it? Well, with orthopaedics, we have commissioned through the NHS England contract of independent sector providers, we're working with the Horton to do some more orthopaedics, and we're going to look at trying doing extra lists after Christmas to start to chip away at that. We are also working with for ophthalmology, there's been a lot of activity doing, I think I did over 200 cataract lists in the past couple of weeks, which were extra, 200 cataract procedures, which were on top of their plan, try and start recovering that, and that's ahead of a Vanguard that starts next week. So again, all things that start to bring those numbers down, and they are being clinically prioritised based on length of wait along with clinical need as well, because of the over activity that's been done within places like BHT. As you'll see on the graph on the left, the actual is higher than the plan at the moment, and that's basically trying to highlight the lengths they're going to try and bring that volume of 52-week waits down. Starting to capture now the risk of harm of those delayed patients. I think the positive to sort of bring out from here that it is divided up into 3 areas of significant, moderate and mild harm. They are all moving in the right direction, which is those patients are going down. They are the ones which are being prioritised going down, particularly significant harm. They're the ones feeding through those services to be prioritised and seen as soon as possible. We do still have some challenges where we are looking at where other services providers can take on those patients, and patient choice is still factoring into people not choosing to go to places a bit further away, whether it's up at Banbury or even down to Reading. And then we started to work across the system around really this interface work, which Raj knows sort of has been close to your heart, along with Raj Thacker and many others, which is just to try and join things up a lot more between primary, secondary and our community. There has been a workshop, there is more work planned. We've got a nominated leaders within Jane Butterworth within the CCG. So again, expect more on this, but because it is a key area that we want to join up, make sure we don't miss any opportunities, but also we understand the impact of what one part of the system does, what it might have on another, and making sure that that's identified earlier on and it's discussed earlier on rather than after the event. I think will be a key feature going forward. And a lot of these items within this pack at the moment, we'll always have the highlight reports, we'll always have the performance, but we really want to take this as an opportunity as queries arise from anyone on the group that we can start to populate that ready for next month. So if things like this and adaptations on this are required, then I'll bring it back. Otherwise, I may ask that or whether the governing body wants Jane to sort of feed in at a future date on updating around that.
Neil, I was interested to see that 2 communications have been prepared. I'm not sure that the CCG clinicians or myself have been cited on what those look like. Could we please make sure that it is passed by us before it is released? I've got great confidence that it'll be correct, but just want to check it with a broad base of clinicians within the CCG before it's released in either domain.
Completely agreeing. At the recovery board the other week, Raj Thacker also highlighted that as well. I think both you and I know that there's been a few bits which had the potential to cause a lot of frustration if it had carried on without our input. So yeah, it's something that we're having to keep pushing through a little bit. We're just having to remind people, but yes, it will be done. Thank you. This were the last sort of few bits of the pack I won't necessarily go into, but it is just to sort of talk about the second surge work and the trigger work that's been done, where we have been sort of modelling, looking at capacity levels. A pack has been created now to get people ready to understand actually as demand goes up, what impact that may have. It's been collected in a rather large Excel document. It's got it from everyone from primary care to community care to our independent providers to mental health. It's literally got everyone talking about what their triggers might be. The next step that we kind of see from this is to make sure the next party has sight of this, so people can start to see, well, if something happens in secondary care and that forces them to potentially prioritise and step down services, we need to understand what impact that will have further up or downstream. So that's the next exercise which each area is going to be looking at. But if anybody would like a copy of that, more than happy to share it around. I can send it on to Russell if people would find that useful. And as I sort of mentioned earlier, there has been quite a lot of work that the communications team, again, probably heavily driven within BHT, has prepared. So they've started to give an update in the rest of this pack. I won't go through each of it right now. Probably, Kim, you may want to have a little bit more of a look through this. I'm happy to pick up a conversation afterwards. But I think we've all been concerned about what has been happening around sort of comms from parts of the system and what we might want to do going forward. This just starts to say how BHT have now articulated that. I think probably our opportunity now is to join that up and try and sort of maximise how we reach out to stakeholders as well as patients.
Yeah, of course.
Thank you, Neil.
Any questions?
Del.
Thank you for that presentation. There's quite a lot to get through there, and I appreciate the report. It's in a very easy format for us to look at. My question relates to the outstanding and overdue action, so kind of on page 57. I'm not assured when we just say, so the first one, BAME Senior Management Plan is in progress, because the options, it looks like it's a default. It's either completed, up to date, done and assured, or in progress. So I just have a question about whether we could put some narrative, and also something like that to be outstanding at this point is reputationally, I think, an issue for us. So I'm just interested in seeing whether the in progress is the default position, and if that is, then we know that, but also maybe some narrative and all the things that are overdue would be helpful.
Yeah, no, you're absolutely right there. So there, within the document that we have, which sits alongside this, which I kind of take a snapshot out and put in this slide, there is commentary which gives a little bit more of an update about what's happening against each of those in the progress. So that's kind of one bit. So again, it probably would be useful for me to share that around so you get sight of it. But there's always room to add a bit more information in, particularly around significant areas of possibly risk that we have there. I think the other bit is that this pack was based on 3 weeks ago. I'm basically, if we had this meeting next week, I'd have a new pack which would give a different status for many of these. So it is a point in time which has some further updates, but let me see what I can pull together for you, particularly for next month, just to help. And even if that is just pulling around a little bit more narrative on those which are either of greater concern or because they've expired.
Thank you, that's helpful.
It's the eternal challenge, isn't it, at these governing body meetings, which is providing enough of an overview without drowning in the detail versus the level of detail you need for assurance. I think, I mean, personally, I found that presentation excellent, and I think it reflects a massive amount of work by Neil and a very small band of people. I think your position in the ICP is really facilitating some of this work. And so I just wanted to acknowledge that the amount of work that's gone into this. And I think for governing body members that aren't as close to it, I think there's an overarching recovery board, and then there are work streams that inform each of those slides. And for what it's worth, I think it's given us a greater insight and level of granularity about what's going on in Buckinghamshire than we've ever had before. And my kind of plea would be that we retain this even once we've got through COVID, so that we might get much better transparency about what's going on. So I think that was really excellent, Neil. Thank you very much.
Thank you, Roger. Really appreciate that. And like I say, it is a small team, but it's a collective effort. So thank you. And I think the main bit is, and particularly to your point as well, Dal, the best thing about this is a snapshot. Any detail you want, we have in the background. It's simply ask and I'll do it. There's no point in sending it out each time because it'll get lost. But yeah, any questions, I've got it all sat there ready for you.
Any final questions or areas that you would have thought would have been covered that weren't? Thanks again, Neil.
Thank you, everybody. Apologies, I've got to go off for another meeting now, but if there is anything after, just let me know.
Brilliant. Which brings us on to the October Q&P report. And is this going to be a double team of Francis and Karen?
Yes, and it will also complement Neil's presentation. So it was very interesting to hear that. So good morning, everybody. Hope you're all well. So to complement Neil's report, I don't want to, to duplicate. So just like to pick up on a few areas. The first being diagnostics. So yes, Neil mentioned the capacity issues that are currently experiencing. So I thought I'd add a little bit of detail and especially linked to BHT on that. So the main areas of risk where numbers are increasing, not only in total, but the under 6 weeks and the over 6 weeks, non-obstetric ultrasound, cardio echoes, MRI and CT, gastroscopy and colonoscopy. So those are the main areas. If you want more detail, I can provide that. On RTT, The September figures show that the under 18 weights were actually in September were lower than April. Those waiting 18 to 40 weeks, there was an increase compared to April, as were the 52 and the 52 week plus weeks. So the overall volumes of the waiting list are relatively stable, slight increase in September, but the movement is in the different waiting groups. So Neil mentioned, sorry, I'm just looking at my notes. I haven't had a huge time to prepare because, as you probably know, I'm also sort of spending most of my time working with the ICC, working on EU exit and developing their reporting. So my notes, so apologies.
Don't worry, and I'm just wondering, firstly in the interest of time, and secondly because I'm sure members have had a chance to read the report, whether we might just invite queries on the data that you're presenting. I mean, do people have any questions, or are there any areas of particular significance you want to alert governing body to, Francis?
So I was just going to pick up on the diagnostic task and finish group, because I also provide project management for them, and to they've agreed that image sharing across providers will be looked at, reducing DNAs, looking at the Richard reports, what interventions can be picked up there, and also the pledge to achieve the 0-6 week breaches by the end of March, linked to the demand management. So that's ongoing work. It's in its early stages, but Rose is leading that, and that will develop. So the other thing I wanted to mention was I had a query from a GP about referrals from private consultants referring into the NHS, and I think that's quite key in terms of the trajectory, where there is an increasing number of patients being seen within the private sector and then transferring into the NHS with perhaps a view of jumping the waiting list. So I've discussed this with Andrew McLaren, and we have agreed for the 2-week wait that patients can be referred into a 2-week pathway straight to BHT through the office by the consultant, but a GP referral is required retrospectively, which will mean the patient isn't affected, but the process will then be able to be followed. For other specialties, private consultants will need to be referring into the triage services where available, and otherwise they will be a referral back to the GP. So apologies if we're creating additional work for GPs. That certainly isn't what our intention is, but it's about fairness and equality for the patients, and also to be able to achieve the trajectories that Neil is working so hard to achieve. If we have people popping in earlier, we're going to achieve that.
Could I just ask about that, Francis? Because I agree. I think there are very clear laid criteria for transferring from private to NHS care, and I think actually there are very few barriers to that. The bit I wanted to ask about was why it's necessary if a private consultant refers to the trust with a 2-week wait referral, and that referral is acceptable to the trust. Why does a GP then have to do a retrospective referral? I don't believe it adds anything to the patient care, and I'm not sure what it adds to the pathway.
No, it doesn't add to the patient care, Raj, you're absolutely right. What it does mean is that the completeness of the record on the PASS system is complete and then can be identified. So unfortunately it is mainly for record and charging and what would normally be PBR purposes.
Really happy to take this offline, but I don't think that's a good use of busy primary care clinician time, and there's got to be a workaround.
Let me. I understand, and so it is important to. We'll go back to Andrew and see what we can do. What I didn't want to do is prevent 2 patients being delayed, and that was the easiest way to do it.
Sure, but I think in terms of principle, I think to involve Raj Thakur into those discussions and to make sure that it's consistent with some of the interface issues that we've principles that we've discussed would seem a really good idea.
Okay, yeah, okay, but I'll see what we can do.
Thank you.
So just on my EU exit role, which could impact on performance. A couple of issues that came up at the Thames Valley LRG yesterday is the potential shortage of water chemicals. Now, I don't want to be telling people what they already may know. Are you aware of this? So there's.
Is this to do with the testing?
No,
okay.
No. This is the update from Thames Valley Water, where there is a potential shortage or an expected shortage of chemicals that are used to treat water, both waste and clean, after EU exit. So the water providers will hold 2 weeks worth of chemicals. Chemical providers will hold 4 weeks worth of chemicals, and unfortunately that can't be stockpiled anymore. So the contingency is in bottled water, but obviously if the mains water supply is affected, that's going to impact on hospitals and performance. I'm afraid I haven't got any further details at the moment, but it's a weekly meeting and I can provide updates. The other one is perhaps not so Bucks related, but more system related, where there is areas of rural Oxfordshire where NHS sites have been identified relying on heating oil. And again, if there's a shortage, they will also be impacted for their ability to carry out their care.
Thank you.
And the only other thing is the highlighted work of workforce within social care.
Just expand on that slightly.
There is expected to be a shortage because social care depends on the EU, a lot of EU workers. They haven't got any further details on volumes on that at the moment.
Thank you.
If there are any specific meds management issues or anything that anyone is concerned about for EU exit, if they can flag those to me, I will raise with Linda Baker, the NHSEI rep, and I will take those forward for you as an ICP, but also as a system.
Thank you, Francis. I'm going to try and draw this section to a close as soon as I've dealt with the 3 hands, which is Graham, Robert and Tony. In that order, please.
Yeah, so Thames Water, for example, you're talking of, so the problem is that if we don't get a deal and it applies to anything, anything like that, so we won't be able to get these things in. But isn't that slightly doomsday scenario? I mean, the cost of these things might go up, which is obviously not ideal, but there's nothing to stop us getting all these things, is there?
It has been flagged, the water chemical issue has been flagged as a national issue on the risk registers, so they are.
So for example, that seems quite a key thing that we're going to need in this area: clean water and Thames Water. Even if it doubles in price, quadruples in price, we'll get that stuff, won't we?
It's imported, so it's the import issue that it may not be imported in the quantities that it's needed initially to maintain the supply of clean, dirty water waste that we recognise, we rely on.
I think we've highlighted it.
Yes. Okay.
it doesn't sound like it's in our gift to fix it. So
I think we've sort of gone on a tangent in terms of EU exits. So I think we need to find a way of flowing that type of thing through, but in a more structured way rather than going into the detail on a tangent. I did have some questions on some points on the actual performance report. If I can just quickly bring us back to the item. So there were two things. So one is, I think, just to highlight the learning disability health checks. And the importance of that. I think we've got some significant work to do in the next few months around that. It's also part of the ambition around the GP COVID mention letter that we received the other day in terms of achieving that. I think that and health checks for SMI we are struggling with as a system, and I think we need to have a sort of refocus on energy on that. The other one is the CHC information in this seems to be extremely old, doesn't really seem to pull through the reports that come to the CHC transformation group. So I think, again, probably to pick that up offline, but just to give people some assurance, we restarted the CHC assessment process. We've also we started with about 250 deferred assessments that had accumulated through the period that CHC was suspended, and we've got a sort of recovery plan trajectory that probably takes us through at the moment to about sort of mid-February to work through those.
Can I just bring Karen in on that? Because is it on CHC, Karen?
It was actually on the LD stuff as well, because I was just going to say that obviously PCNs are looking with Shan's help at the LD health check and how they're being addressed locally. So there is a lot of work going on to improve that, and not just to improve the uptake, but to improve the quality of what's actually taking place. And the SMI is closely following behind that piece of work. So it is being addressed at PCN primary care level, which is quite reassuring. I think that'll be quite a positive step forward rather than being just the practices alone looking at it.
Thanks, Karen. Sorry, carry on, Robert.
Yes, so fine. And just to finish off on the CHC, so I said we've got a recovery plan, which monitoring. We put additional capacity in through Oxford Health, and the final thing is to say that there were no assessments done in hospital during September, because that's one of the targets on here in terms of assessments in acute. I think that reflects all the work that's been going on in terms of the sort of discharge assess and the hospital discharge process. While some of the formal targets will take time to rebalance because they're cumulative, I think we've got, just to give assurance that we have got oversight on the CHC sort of process as a system, as a CCG.
Thank you. Tony, you've put your hand down, but please make your point.
I put it back down again because Robert's dealt with the CHC question.
Thank you very much. Russell?
Mine was also just a quick comment in relation to CHC. It was whether or not colleagues were aware of the Parliamentary and Health Service Ombudsman report published last week with a number of recommendations for CCGs around obtaining assurances on training and learning of staff who are providing frontline nurse assessment, recognising the ongoing recruitment challenges we've had in that area.
Thank you. Can we take that as an action to take offline and review? Thank you very much. Thank you, Francis. Karen, was there anything you wish to add before we move on? We are running about 20 minutes behind now. Thank you very much. Thank you, Francis.
Thank you very much.
Kate, sorry to keep you waiting.
No, it's no problem. I'll try and share my screen, but I think you've all got the report anyway, but just so you have it. Does that come up? Yep. Has that come on screen? Yep. Brilliant. Okay, thank you. So there's three things I wanted to update committee on, if that's okay, please. So month 6, and then following on from the comments James made earlier about months 7 to 12, and also the risks associated with that, just so governing body are aware. I'm conscious of time, so just to remind committee that that we changed finance regime because of COVID, as you'll be aware. For months 1 to 6, initially we had an allocation through month 1 to 4, and then that pushed out for month 5 and month 6. So month 6 is the last month of that regime. So we had an allocation, and then we have been retrospectively reimbursed for all reasonable costs associated with business as usual issues and also COVID spend. And that includes the hospital discharge programme up to the end of September. That also relies on the fact that we have national block arrangements for acute providers that you'll all be aware of, and also that the independent sector is contracted and paid for centrally by NHS England. So as a CCG, we have, I'm pleased to say, had all our retrospective claims reimbursed up to and including month 5. Month 6 process is going through at the moment, and we're working through the assurance process with NHS England for that. That's been delayed a little bit at the end of this regime, and they're going to do the top-ups into month 8. So when you see the report for month 7, it will also include the overspend for that relates to month 6. We've answered all the questions that they've pushed back, and we are fully expecting to be reimbursed. So we are fully expecting to be reimbursed in total and a break-even position for months 1 to 6. As I say, so as James reported earlier, we have then put in a plan. The regime is changing from month 7 to 12. So there is a control total that comes through. The CCG has an allocation, and that control total will link into the ICS control total. There's also been additional allocations at ICS level for COVID spend and also for recovery spend. And there's been a process of working that through as how that fits into organisational plans, and those plans were submitted, as James referred to earlier, at the beginning of October. Working through those, and the ICS plan was £37 million deficit. The CCG plan that went in was £6.3 million deficit, and that mainly relates to differing views nationally for prescribing and CHC. So for example, for prescribing, we were given a percentage within the allocation we received, and actually what we're seeing locally is higher than that. So that's been worked through, and that is being pushed back, and that's part of the discussion that James referred to earlier back with NHS England of national known elements. Excuse me. The £6.2 million deficit on the business as usual also assumes that we as part of the ICS allocation, we received 3.6 million for COVID spend, and that assumes that we will be able to control our spend for COVID within that 3.6 million. And it also assumes that the hospital discharge programme and hospital discharge scheme, because there's two schemes running now, one pre 31st of August and one post 31st of August, that both of those schemes be reimbursed, continue to be reimbursed separately from central sources. So we are waiting for the outcome. As James referred to, we're having conversations back with the NHS England team, and I'll be able to update committee next month as to where we're at on the plan, etc. So just in terms of that, the risks that I'd like to highlight are the fact that we can't continue, would be if we couldn't continue to control our expenditure within that deficit plan that we've put in. We are fairly confident at the moment that, you know, our figures are robust. We have been through that on an insurance program process with NHS England. So, but there is still a risk that I need to highlight to you. Also, when we did the phase 3, the wave 2 of COVID wasn't planned for. And as such, any costs associated with wave 2 could cause us a pressure on top of the 3.6 COVID we've got. We have highlighted that within the plan and put about £500,000 risk in for that, just so that you're aware. And there are funding flows coming down centrally. So as Robert's alluded to, there's an additional 150 million that's come just this week, relating to COVID, etc., and supporting to primary care. So things are moving quite quickly at the moment. And the third thing is that continuity. There is no indicative allocation of hospital discharge programme or hospital discharge scheme. It is a national separately funded stream, but it's just to highlight that we are expecting that to flow, and that could cause us a risk if it stopped for any reason. There's no reason to expect it to, but it's just to point it out. I think that's all I was going to say, unless there's any questions from anybody.
I was going to invite any comments from Tony as chair of the Finance Committee at this point.
Raj, we've been monitoring this carefully at Finance Committee. I know the team are working hard on it, so I've got no particular issues with this.
Thank you very much. Robert?
Yeah, the project dropped out for a second, so if it got covered. But I think again, governing body just needs to know that we need to work through and starting to work through the implications for future years on this. I think our sort of I think the cost base and sort of what we spend our money on the system could have shifted quite significantly this year, as we've sort of spent money based on sort of responding to the COVID. So again, I think I'm sure we'll come back to it as we get into 21-22 planning, but just to sort of note that for governing body.
Thanks. Yeah. Thanks, Robert. We are starting to do that work, as you know, and we have a committee with Finance Committee that we will bring that back through, and we are starting to work very closely with BHT colleagues to understand the impact there, and also with mental health colleagues to understand the impact into 21-22 of the mental health investment standard going forward, etc.
Thank you very much, Kate. It's really
okay. Helpful. Thank you.
I'm now going to jump to item 13 and welcome Catherine Mountford and Bashak Arnold to governing body to discuss the EPRR. Welcome.
Thank you very much. So for those who don't know me, I'm Catherine Mountford, one of the Oxfordshire directors, but I've been the accountable emergency officer for Buckinghamshire CCG for just over a year, and I obviously support Bashak and Nicola in their work, and thanks to them for all that they do. This is the annual update to governing body, and as everyone is aware, it's been a very interesting year. During it, we implemented a combined on-call rota across the two CCGs, so I would like to thank all the directors on call for the adapting to that in the first few months of this calendar year, and then picking up COVID response. And of course, we've spent most of the year actually testing our emergency planning arrangements as we've responded to and recovered from managing an incident like nothing we've seen before. There's been lots of learning from this, which has actually formed the basis for this year's report to the governing body and assurance process. So it's not been done in the same way as previous years. And I'm now going to hand over to Bashak, who's going to highlight and outline the key points from the report that you've got.
Thank you, Catherine, and good afternoon, everyone. It's Bashak here from Buckinghamshire CCG as the System Resilience Manager for the organisation. So EPR assurance is something that we do each year to demonstrate preparedness for emergency response and resilience. As part of this, we carried out the assurance process for this year, which covers 2020 up until 21. As Catherine has mentioned, it's been quite a difficult and different year for us because of COVID-19 response. But I think this showed us as an organisation and more widely across the system that what we can do together when we all bring in the forces. So for this year's assurance process, it was quite light touch. We didn't have to go through the very heavy core standard assessment process as we did last year, but we still provided evidence that we are working through the actions from the last assessment period, which actually has shown an improvement. Last time we had, I think it was around 3 areas that we were not fully compliant with. I'm now pleased to say that we just have 1 area remaining, which means that we are partially compliant with that part. But overall, as an organisation, we continue to be substantially compliant, which is still a good progress for us. So the area that remains as partially compliant for this year is around the governance process. And we have identified some ongoing work around this because now we are starting to work a little bit closer across the CCGs, and we realize that this action will be picked up as part of the wider bot working. So we haven't had any response coming back from NHS England, but the initial conversations we have had with them has shown that they were happy with our response because we have been able to demonstrate our preparedness for wave 2 of COVID-19 planning. We have taken on board the learning from the first wave, and also we have looked at our winter preparedness amongst everything else. So I think they were quite pleased with the work we have done so far. And just to note to everybody on the call, we have a number of UEC work streams that are ongoing to support this work as well on a wider footprint. So this will all be making sure that we are as prepared and resilient as we can be for any upcoming incidents beyond COVID-19, but we are yet to have our formal meeting with NHS England alongside other CCGs as well. As part of this process for this year, we have also sought assurance from our provider, Buckinghamshire Healthcare Trust, and again, they have shown a massive improvement from last year. They used to be substantially compliant, and now we are pleased to say that they are fully compliant, which is a major improvement from last year. So overall, I think we have a good action plan in progress. We know where the gaps are, and we are working collectively to address those. So I will leave it at that for now. Thank you very much.
Thank you very much, both. Any questions? Must have been Robert.
Yeah, not questions. I just echoing Catherine. Really, I think it's brought it in sharp focus about what emergency planning and response is. Although obviously this isn't an instant way, but I think both the preparation beforehand, the ability for us to swap and for people to be comfortable to working in sales, and then sort of the continued reprioritization, I think is testament to how much sort of training and understanding people had of the process. And again, just to thank sort of Catherine Bashak and the team really about I've always felt confident that we've got our sort of back, if you like, in terms of things we need to be doing in quite a challenging time really. So just to echo that.
Yeah, no, I'd fully support that, and I'd like to thank you both for your work on this, and thank you, Catherine, for the role that you're taking on for our CCG. Thank you.
You're welcome. Thank you.
Okay, we'll now go back to item 12 on the agenda, which were three sets of decisions around corporate governance and constitution. If we could try and get through these as efficiently as possible, Russell, that'd be good.
Yeah. A is basically a formality ratifying the reviewed and updated terms of reference for the Quality and Performance Committee. The other committees of the governing body were reported to the same effect earlier in the year. There's been some known challenges around convening the Q&P committee for the obvious reasons around managing the pandemic. So that one's taken a little bit longer to complete, but has now been. So I'm just asking for formal ratification of those, please.
Any comments or observations? That is even more efficient than I was expecting, Russell. Thank you.
There you go. 12B, which is again a repeated item that I've brought to governing body before. The first part of that is our decision logs. You will recall earlier in the year there was HSJ coverage that suggested that at some point there may be a increased risk of legal claims, and we had a discussion about the time about the extent to which that may or may not materialise, which is difficult to make a judgment on right at this time. But for completeness, there is the decision log process, and I am reporting to governing body what has been included on that at this point in time. And the decisions that I have logged are only those at this point in time in relation to integrated commissioning. Just to note, it includes only those decisions that have been added to the decision log since it was last reported at governing body in September in public.
Are there any queries about the entries in those logs or the process? Thank you.
Great. And then the update on where we were with the financial submission, the COVID cost submission, which is no different than what Kate has already reported under finance.
Okay, governing body happy?
Yep.
And then the final bit, 12C, which is a couple of sets of amendments to the scheme of delegation. One is in relation to delegated authorities to the integrated commissioning executive team. You might recall that previously we had adjusted the constitution that showed a line of accountability for the ISET into the governing body, in addition to the line of accountability that it has to the Health and Wellbeing Board within the council. And this is now just formalising some of the existing delegated authorities that are afforded by governing body to the exec, but are now extended to the CCG's members on the integrated commissioning executive team, as opposed to the ISET itself, given that the ISET as a collective is shared between us and the council. So that's all that paper does. Okay. I mean, Robert, I don't know if you want to touch on any of the detail of that as or Karen as both active members of ISET.
No, I think obviously we've got clinical and managerial members on that, if that helps. I think I was just sat here reflecting. I think we did that, and then we sort of didn't have ISET for a few months in the early days of the pandemic. So probably what we need to think through now is how we report back or make sure that there is a link between ISET and the governing body. I just sort of sat here reflecting, sort of either through items that we bring here, specific on areas such as mental health or LD we've talked about earlier, or obviously it's feeding into the various reports. But yeah, I was just sat here reflecting about we just need to make sure that the governing body could sort of has assurance about the work of ISET.
Is that a query we could take offline and work out the best?
Yeah,
way?
it was reflection. So it's probably giving myself an action towards you, Raj, to sort of go away and work with Tracy Ivanmanga, who's the director of integrated commissioning, to sort of work through how we do that a bit stronger. So sort of giving myself an action there, I think. It
would be a good principle to try and establish as we delegate more stuff into different arenas in any case, just to make sure that we retain the link back to governing body.
Yeah, no, I agree, Raj. Yeah.
Okay, lovely. So that part of governing body was the part for decisions. So are we happy to approve papers 13A, 13B and 13C?
Yep.
Yes.
Thank you very much.
Just apologies, Chair, just to note that the other part of the changes to the scheme of delegation, it's challenging because of course some of this is technical stuff, yet at the same time it is owned by the governing body, hence I bring it. Some changes to reflect the delegated authorities within a subsection of the scheme of delegation around the integrated community equipment service. I did bring a set of changes on this previously to governing body, based on my understanding of the integrated commissioning team's expectations as to how those thresholds would work. They've subsequently come back to me with some other comments and some tweaks and changes, and therefore the update that you've got here reflects those tweaks and changes to the scheme of delegation. So that's all I wanted to say on that.
Thank you. We remain supportive of the changes. Great. Okay. On to item 14, which is primary care networks and the additional roles and reimbursement scheme, noting the declaration of interest that the clinicians made at the beginning of this. Robert?
Yes. So I think if I just start off and then I think probably Rash is probably best position to sort of give a sort of general view about how things are going PCM wise, but just on the additional role specifically, you've got what I would describe as sort of the technical background paper for information about sort of what they are and how they're reimbursed. In terms of how we're doing that, we've made our submission for the recruitment that's planned through the rest of this financial year. I'm really pleased to say that with the help and the really hard work of I have to sort of single out Wendy Newton in the primary care team in terms of all the work she's done with PCNs around this. We are currently predicting to fully utilise the nearly £4 million of resource that's available for additional roles in this financial year, which I think is represents a significant increase in sort of capacity and recruitment into the primary care workforce, which is obviously to be supported, but obviously comes with challenges around recruiting a large number of staff in a short amount of time, which I think we need to recognise. In terms of our plans for this year have been approved by NHS England. We've put in, I think, on Tuesday, which is a verbal indicative plans for 21-20. For next financial year up to 23-24. I just to give you an indication of the sort of numbers. I think we had about 9 posts in the 1920, 9 sort of full-time equivalents in 1920 in terms of posts. The planned recruitment over the next 19. Just look at my numbers, 19, not 9. The planned recruitment in terms of full-time equivalents over the next few years is 184 in this financial year, 107 next year, 58 the year after, and 81 in 23-24. It's a very significant amount of recruitment. And I think I said earlier, I think as I sort of talk through with the PCN accountable clinical directors, things like the estates and the IT to support that workforce, as well as the ongoing training, recruitment, re-recruitment when people are promoted or leave, obviously comes up as a theme. So I think, again, we need to sort of not treat this as a one-off. We've put some numbers on a spreadsheet, and these people will just appear, and just recognise this is a significant increase. That's a sort of a very sort of general overview of where we are. Obviously, we can bring back as we progress about sort of the fulfillment of those roles. Rashmi, I don't know if anyone else you want to add in terms of sort of general PCN development.
Just before Rashmi comes in, I just wanted to pick up on a couple of things that you've quite rightly highlighted. I just want to provide some background to governing body and for the lay members in particular. This is a key vehicle for the sustainability, the future proofing of primary care, but more importantly, for the model of patient care that's articulated in the long-term plan. I can't overemphasize how important this piece of work is. And the reason I'm prefacing what I'm going to say with that comment is that there is some evidence that our system in Bucks isn't as joined up on some of this work as it needs to be. And Wendy Newton, from our organisation's point of view, has been instrumental in the work that's been done with networks and to try and produce the workforce reports and much of the important groundwork that is vital if this is going to be a success. And it's an ambitious target we've got for networks. And so Jessica Newman and I have had conversations about, how we can utilise the work that Wendy's done and for it not to be lost. And so we are going to meet with Rebecca Tyrrell from the Training Hub, and we are going to ask for Wendy to have a seat on the Training Hub board, because I think anything else would be a real risk to the system. And so what I'd like is governing body support for that proposal to the Training Hub board. That Wendy Newton probably has the greatest level of knowledge about this stuff and could contribute more than any other individual that I can think of currently. I'd like your support or any views on it. Robert?
Yeah, happy to support. I'll link you and Jessica into sort of the latest conversations around system support, Raj, because I've seen some stuff over the last 24 hours in terms of how it feels a little bit more connected on that. So I'll make sure you've got that before your meeting. But yeah, no, as you know, I'm being a great supporter of making sure that we have the right people in the virtual rooms to have the right conversations, irrespective of what organisations they have a label with.
Indeed. Thank you. Tony?
It may seem a strange question, but you certainly have my support. I wonder how easy it will be to recruit experienced people to these roles.
It's our single biggest risk, Tony. That's why we can't afford to have any false storms and kind of missteps along this process. Everything needs to be aligned for us to have a fighting chance.
So I think just talking about, I think my reflection is, I think we need to not think of this as a sort of one-off exercise. We need to now think that we're in a permanent recruitment process for primary and community staff and treat it that way. I mean, it's going to it's something like 800 whole-time equivalent over the next 4 years. Even if you got everybody in the first round, people are going to leave through that process, get promoted, get other jobs, be on rotation, etc. So again, the sort of support I'd be looking to for the system with the PCNs is how we actually treat it like an expanded workforce. And if you treated it like a division of one organisation, you'd have some significant HR support in that process.
Can I bring in Rashmi at this point?
Thank you. I think PCN development has come a long way from last year to this year, although it's not, when we say PCNs, it's not uniform, because there is a different level of maturity with different PCNs. Those who started earlier came together earlier to those who sort of came on later, and the same has happened with recruitment as well. But I think there have been some notable successes in terms of, for instance, the care homes SNS and the way PCNs have come together with the DES as well to deliver that. The realignment of care homes to PCNs, and you can see that practices are working together and understanding, closer working, and being more patient-centered, and I think everybody has their heart in the right place, and the mindsets are shifting from just practice alone to population health and PCN and looking at a wider footprint. I think the PHM pilots, the action learning sets, again, have been very, very positive with the 3 PCNs who are engaged. But again, they're looking at their data. So again, they're learning to look at the wider footstep and to see how they can look at the specific needs of their population. So I think overall, there's a lot of good work happening, whether it's with the pharmacists, whether it's with care homes. And I think the new challenge that PCNs have is the COVID deaths and how they're going to be able to deliver at speed the COVID immunization. I think as the CCG team, we've taken on a very facilitative and supportive approach. We are, responding to feedback, taking them with us along their journey, trying to develop, some key matrices for them to follow and see. And with our SNS team, we are still meeting with them fortnightly, but we're trying to bring up other issues as well, so that practices can give, or PCNs can give us feedback. I'd be, grateful if Karen or Dal had any comments from their specific areas from the north and south, or any feedback.
The only feedback I have is the positivity around the recruitment to these additional roles. There's a real buzz and a commitment that things are progressing, and they're seeing that in the workforce. So that's probably the only thing I would report back.
I think the one thing I would say is that there's actually quite a lot of variation still, which I think we need to be aware of and address, whether it's in a training format, learning between PCNs, or how we manage that, but there is definitely quite a lot of variation still.
Thank you.
Again, on behalf of the governing body, I want to thank, Rashmi, the primary care team, who I think have really conducted themselves in a very positive way, and that's why PCNs have responded and continue to engage as well as they do. So thank you. Can we move on? Thank you. Now the remaining 4 items on the agenda are for information, but I will take advantage of the fact that Kim is here to see if she's got any highlights to give us on the communication engagements report.
Thanks, Raj. I just wanted to flag a couple of things, really, not go through the whole thing. Obviously, this period of this report, which is Q1 and Q2, has been completely dominated by the pandemic and the comms around that. And what I would stress is that we've been doing that predominantly jointly. So we've made great use of the council's channels. So you'll have seen there'll have been quite a lot of NHS sort of information out to residents through Martin Tett's newsletter, which was reaching over 220,000 residents, and that's gone out. At one point it was going out very regularly. It's down to 1 or 2 times a week at the moment. And alongside that, a lot of work supporting GPs. So in the early days of the pandemic, we were doing daily briefs out to GPs. We're now down to doing that 3 times a week. We did look at reducing it, but it was very well received. So that carried on, and there's continued to be lots of information. The other sort of thing that has dominated our work has been the health and care services engagement work that we've been undertaking. I think Robert mentioned it earlier. The initial phase 1 was the survey that we did, and that's finished, and the analysis, we've had the initial analysis back on that, so I'm sure you'll see more on that shortly. And we're moving into phase 2. So phase 2 has been a workshop which has already taken place, and the next stage is recruiting people to attend focus groups to try and make sure that we're reaching as many people. So we've identified different groups that we want on that focus group, whether they be carers, people from the BAME communities, those that maybe are more affected by use of digital services. So there are about 12 focus groups that will be taking place. And then the final aspect is preparing for winter. That's taken quite a considerable amount of time in the run-up with flu, Think 111 and various other aspects. If you live in Bucks, you may have received the council's newsletter, which is your Buckinghamshire new newsletter magazine from the council, and in that there was an insert for preparing for winter and getting ready and services that people will see. So those are sort of the three areas. What you will see in the report is that just because those have been, well, particularly coronavirus has been a huge part of our lives, there have been other communications going on. So during the pandemic, the lockdown phase 1, we had a massive Help Us Help You campaign that we supported, the NHS England campaign. So we have been promoting other services as well during this period. And finally, if you just indulge me, I'd just like to say a huge thank you to all comms colleagues. They are a team. We are a team that has been at the front line, although hidden away front line for the last 8-9 months, and a very tired team, but still going on and still coming up with great ideas and working really hard. So sorry for that, but I just wanted to say thank you publicly to all my colleagues that have worked really, really hard over the last 7-8 months.
And in a similar vein, I think Governing Body would like to thank the communications team for the sterling work they've done over the last 6 months. I don't think I've seen quite as much activity going on as has gone on in the last 6 months. So on behalf of us, could you pass our thanks on to all the members of your team? They've been
Thank you, Raj.
They've been a pleasure to work with.
Thank you.
Robert.
Yeah, just to echo it, and certainly when I talk to people, that the further information out through the sort of primary care COVID bulletin is really valued, and I know how to, the comms team were instrumental in making sure that was focused and robust. I think the other thing which I can't quite see highlighted in the report, but apologies, Kim, it was in there, is again just thanks to clinical colleagues who at the early stages of the pandemic did a number of webinars and topics with both the sort of public facing blogs, if that's the right technical terminology, as well as to sort of care homes, etc. So again, I think they were invaluable sort of reassurance to those sectors to hear from sort of local clinicians. So again, I just wanted to highlight that piece of work.
Noted, and thank you, Robert. It's not the most favourite part of some of our jobs. I don't believe there are any questions in advance for this governing body, and so I will just invite any questions from the floor. Good. Just to note, Chair, that the response to the question raised at the AGM on long Crendon surgery is documented in the minutes from the previous meeting. Thank you. And then the final thing, I think, is just to draw your attention to the Learning Disabilities Mortality Review, which I think is an important document, and governing body can be assured that we will be reviewing that and working with our clinical lead, Sian Roberts, to ensure that any learning from it is captured. And again, that's another area, just like the serious mental illness health checks. I think learning disability health checks are a very important part of what primary care will be tasked to deliver, even given the demands of COVID. So I just wanted to point that report out, which I think is important.
Can I add something to that, Raj? Sorry to interrupt. It was just to say that actually we've had some really good work coming out of it, and we actually started quite a big safeguarding investigation as a result of a leader report with significant outcomes. It will come out in the next QMP report, the outcomes, but yeah, it's actually, Azil has done some fantastic work on this, and it can't be underestimated, the impact, because I think GPs often think they're just ticking boxes, but actually we've had some real outcomes, which is... I wonder whether a comms back to practices might invigorate them to really cover as many patients as they possibly can over the next few weeks. That's a good point, Raj. Robert.
Yeah, I just wanted to reassure the governing body that I know we've had some conversations today about prioritisation, but just to reassure that the LEADR is absolutely still identified as one of those priorities. And I think obviously it would be great to, and I think we need to recognise that we're in yeah, we've made significant progress. We've still got a way to go, and I think it would be good to see some more of the outcomes in the recommendations completed sort of in the next round. But I said we absolutely sort of recognise it needs to be a priority as we go through the next wave to continue with these reviews. Yeah,
and I think inherent in the word priority is the fact that the important stuff stays at the top of the list, and that we retain focus on it. Our challenge as a CCG is to try and communicate that out to both our partners and our practices, to make sure that they retain focus, because at the moment, there are so many messages and demands coming at them from so many different directions. Thank you. That brings us to the close of the meeting, and our next meeting in public is the 12th of March, which seems an awful long way away. Hopefully we'll be partly through the other side by then.
Hopefully, and just to note, there has been an updated calendar invite that has circulated to move it to the afternoon as opposed to the morning, so that it mitigates against the diary clashes that we know James has, where he goes off to other meetings with NHS England on Thursday mornings.
Hopefully that won't be an insurmountable obstacle for members of governing body, but I guess we'll find out. Look, it's been a long meeting, and it's been a long morning, so thank you very much for all your contributions and attention, and have a good rest of the day.